clinical case presentation by DNB trainees. And today, along with us to moderate here, we have Dr. Deepti Suri. Ma'am is a senior consultant professor at PGI Chandigarh in the Advanced Allergy Immunology Center for Pediatrics. And today, our presenter is Dr. Arun Kumar, who is our secondary DNB trainee. He would be presenting his case. So, Dr. Arun, may I request you to start sharing your screen and to start your presentation, please? Thank you.
Good evening, all. Today, I'm presenting a case having under the moderation of Deepti Suri ma'am, Professor of Pediatrics, Allergic Immunology at Advanced Pediatrics Center, PGIMR Chandigarh, and under the moderation of Consultant Division of Miss Manjari Agarwal, Consultant Division of Pediatric Rheumatology, Sir Gangaram Hospital, Delhi. My patient's information: patient name XY, age 11 year, female, residence of Bihar, informant father, reliable. Date of history, taking an examinations 1st July 2024. Chief complaint, coming with chief complaint of fever for 3 months, complaint of rash over face for 2 months, mouth ulcer for 2 months, swelling over face and both the legs for 1 month. History of present illness: the child was apparently well 3 months ago when she started having fever, which was acute in onset, continues, maximum documented of 1 degree Fahrenheit, completely relieved on taking antipyretics, and comes again after 4 to 5 hours with no diurnal variations, initially not associated with rash, chills, and rigors. After 1 month, parents noticed rash over face, mainly on the nose. The rash was red in color, not associated with itching or discharge. Photosensitive, scaling present, fixed erythematous rash. From last 2 months, parents also noticed child having multiple ulcers over the roof of mouth, not associated with pain or difficulty in swallowing. From last 1 month, swelling over face, below lower eyelids, and swelling over both legs. The child was investigated, suggestive of low HB outside, and for that 1 PRBC was transfused and the child was started on oral antibiotics. And she was referred to Sir Gangaram Hospital for further evaluation and management. Negative history: no history of decreased urine output, blood in urine, dysuria, urgency, burning micturations, no history of any bleeding manifestations, no history of headache, no history of loose motion, yellowish discoloration, and abdominal distension or abdominal pain in abdomen. No any history of cough and weight loss, no history of TB contact, no history of blood transfusion in the past, no history of behavioral changes, abnormal movements in the past. No history of any recurrent infection in the past, no similar history of complaint in the child or any other family member of the child. No history of bone pain, joint pain, or joint stiffness or pain severe enough to disturb the sleep, and no history of prior hospitalization before this episode. Should I proceed, ma'am?
No, Arun, wait. Let's go back to your presenting illness. Dipti ma'am, would you like to question him on the complaints and the history of presenting illness?
So, thank you, Arun, for that case presentation. Now, the questions here probably would be, you have a young girl who has come with fever and rash and oral ulceration, along with swelling over face and both the legs for 1 month. So what inference do you draw from your such kind of, what differentials do you think of when a patient comes with such illnesses? Or what organ system do you think are involved here?
This patient present with fever or complaint of rash or mouth ulcer and swelling, we will include two or three systems. Fever, if it complains of rash, it may be systemic complication. If it involved with swelling over face and both legs, may be due to cardiac or renal involvement. Cardiac involvement or renal involvement. If fever and with rash is such, if fever is less duration, then we may think about viral or bacterial. If fever is such a prolonged history, then we may be think about that any connective tissue disorder with rash, any other malignancy, any long acting infectious disease, we can think about that.
So, Arun, what infections would you be thinking of with such a history?
And think about the tuberculosis or HIV infections for such a long duration history, ma'am.
Very good. So always we have to remember that, sometimes when we look at these patients and, when we are wearing our rheumatology hats, we keep thinking that, okay, this is a rheumatology case. So, or when we are sitting in our OPD and we think that this could be a rheumatology case, it may always not be the scenario. And we have to be, in fact, in rheumatology, the first dictum is rule out common things first. And only after ruling out many things are we able to conclusively, confidently diagnose a patient with a particular disease. So you looking at this, you would definitely, when you have a child who's got a fever for 3 months, then definitely you're not thinking of, your garden variety bacterial infections. You're not thinking of viral infections. You're not thinking of anything but two infections, like you pointed out, tuberculosis and HIV. And rash can be part and parcel of anything. But to answer ma'am's question, you should also say that when we are thinking of this complex of symptoms, then you're going to say that this seems to be a multi-system involvement with a mucocutaneous involvement. And as you very rightly said, the cardiac or the renal may be involved. Looking at these four complaints, this is what we can say. Perfect.
So what is so significant about the oral ulcers? And why is it important? You said mouth ulcers. So when do you think that mouth ulcers are important?
Without pain. In my case, the mouth ulcers are present all the upper roof and without pain. And if mouth ulcers are present painful, maybe due to autoimmune deficiency or any candidal infection, we differentiate other mouth. But in my case, the mouth ulcers are painless and roof of the mouth.
So, yeah, so the mouth ulcers, oral aphthai are very common symptoms that you will encounter in your pediatric practice. But and there are multiple causes of aphthai, but most of these aphthai are painful ulcerations and short-lived. However, especially in patients with lupus, they are painless and they are seen on hard palate or sometimes even in the other parts of the oral cavity. Which other rheumatological illness is associated with oral ulceration?
Kawasaki disease.
Okay, Kawasaki disease. So Kawasaki is an acute illness. So oral ulcerations which go on for months together, or multiple of them. In which other rheumatological illness will you see that?
Don't think of a situation where there are ulcers anywhere else also apart from the oral cavity. So there are ulcers in two areas. One is the oral cavity, one is somewhere else. Which disease?
Ma'am, Other body part, ma'am, with in the hands, ma'am, hand, foot, mouth disease, and
No. So in the genital area. So which
The genital
disease would
area.
you have? Oral ulcers. So Behçet's disease. Yeah.
So
Okay,
oral
ma'am.
ulcerations, oral and genital ulcers are also seen in Behçet's, but they are mostly painful.
Okay, ma'am.
Okay.
Should I proceed, ma'am?
Yes, I think so.
Yes, ma'am.
Treatment history: child has been on and off on oral antibiotics since 3 months for fever. After that, there is no any past significant history, no history of previous hospitalizations, prolonged illness or surgery. Family history: child, second child born to non-consanguineous marriage, no history of similar complaint in family, no history of tuberculosis in the family. Antenatal and natal history not significant. Birth history: child was born to 32 years, para second, complete 38 weeks of gestation, while LSCS. Birth weight was 2.8 kg. Second birth order: cried immediately after birth with no NICU admission, accepted and tolerated feed well. Development history: child attained all developmental milestones at age appropriate time. Currently, she is studying in 7th class and good at academics. No menarche yet. Immunization history: child is immunized up to date till date according to National Immunization Program. BCG scar present on left shoulder. She tolerated all vaccine well. No post-vaccination fever. Dietary history: using 24 hours dietary recall method during pre-illness, child approximate dietary intake is around 1,839 kilocalorie and 43 grams proteins appropriate, no deficiency. Summary: 11-year-old girls come with complaint of fever over 3 months. She also presented with rash over face and nose associated with multiple painless ulcers in mouth and swelling of both the legs with facial puffiness for 1 month. Family history and developmental history and birth history is insignificant. With this story, would like to consider child is suffering from a chronic progressive disease with multi-system involvement, probably autoimmune etiology like connective tissue disorder, infective etiology, tuberculosis or HIV, or any malignancies like leukemia or lymphoma.
So do you still want to keep both the possibilities of it being a cardiac or renal, or can you differentiate on the basis of history whether it is primarily a renal involvement?
Ma'am, I want also kept the renal possibility with the history and along with the because it's multi-system involvement already I explained, and with other systems are also involved. So I've also kept the renal involvement in this along with
So which
this.
histories are important when you're suspecting a renal disease?
Ma'am, edema over the leg and peri-orbital swelling is also present in that renal system in my case, ma'am.
So Arun, suppose this was a edema due to cardiac involvement, then how would you differentiate? This is what ma'am is asking. So how are you going to differentiate between a edema over legs due to a cardiac involvement versus a edema over legs due to a renal involvement?
Ma'am, if it is due to cardiac involvement, the at the morning time edema is less, but edema increased over the day passes. But in renal involvement, the edema is present.
Like, what are you
Ma'am,
confused?
I reversed. Yes, ma'am.
So where is the edema more in renal involvement in the morning, and where is
Ma'am.
it less in the morning?
Ma'am, cardiac edema is decreased as day passes. In the renal involvement, the edema is more probable or periorbital area along with legs.
So in the renal involvement, there is in the morning, when the patient wakes up, there is periorbital puffiness and the pedal edema is less. And as the patient of a kidney disease moves around, the dependent edema increases. So the pedal edema would increase and the facial puffiness slightly goes down because the patient is ambulatory. At night, when the patient is lying prone, then at that time the renal edema increases over the face and decreases over the legs, and it's the reverse with cardiac. So in a cardiac involvement, you typically would not see a periorbital puffiness in the morning, but you would see a lot of pedal edema.
Anything else in the, yeah. So thank you. I think all of you must get this concept clear, as Dr. Manjari has pointed out. So the important point here, the second important would be any other associated histories which help you and what acute associated, what acute complications or with renal, especially if you're thinking that this is renal in origin, what are the important things that you will ask in the history and will focus on in your examination in future, what you're going to do?
Maybe if renal involvement, I will ask for urine output or either any burning micturition related to that. And apart from that, swelling is increased or swelling over all over the body. Either it is present constant or progressively.
What about breathlessness?
Ma'am, breathlessness is not associated. If it involves the respiratory system, then.
So when you have a cardiac cause for edema, do you get breathlessness or not?
Yes, ma'am. I may get the breathlessness because.
So isn't that an important differentiator for you?
Yes, ma'am.
So you would ask for that history, and you've asked that also. No? There's no breathlessness. So you would be thinking that it's mostly renal.
Okay, ma'am. Should I proceed, ma'am?
Yes. Manjari, you have any questions?
No, ma'am. We'll go ahead. Thank you.
General physical examination. Parents' consent is taken. Child was examined in sitting position. Explaining the procedure to parents. The child is conscious, alert, oriented to time, place, and person. Temperature 98 degree Fahrenheit measured with digital thermometer in axilla. Pulse 88 per minute regular, good volume, no radial femoral delay. All peripheral pulses palpable. Respiratory rate with 24 per minute with BP normal and 110/70. Measured in right arm in spine position. Saturation 98 at room air with capillary refilling time less than 3 seconds. Head to toe examinations. Pallor and edema present over perimeter and the legs. No icterus, no cyanosis, clubbing or any lymphadenopathy not present. Head normal, hair distribution is normal, no alopecia. Face erythematous raised rash present over nose and with the periorbital edema and fixed rash. Eye normal, no redness in eyes, ears normal, and oral cavity having ulcers over the hard palate, pain known without any pain. Head to toe examination with no petechiae, purpura, ecchymosis seen on body, skin normal, genitalia, no ulcers seen, normal for age, SMR stage 2. Anthropometry wise, child having weight of 39 kg, lies between 90 to 97 centiles, height 57 centimeter, lies in 50 to 75 centiles, and BMI is 17.3 kg per meter square. Systemic examinations. And respiratory systems as normal, vesicular breath sounds, no added sounds, no distress, serious, no prominence veins or visible pulsations in the precordium, S1, S2 heard normally, no murmur or gallop. No focal neurological deficient, moving all limbs equally. All reflexes are present. And system in per-abdominal examination, abdomen is slightly full with no localized distension. Umbilicus is in central in position. All quadrants are moving equally with respiration. There are no visible scars, dilated veins, or visible peristalsis. Spine and genitalia normal. Hernia sides free. On palpation, abdomen is soft, no tenders, and no hepatosplenomegaly. Tympanic nodes on percussion. Liver dullness is in right hypochondrium. Bowel sounds are present. Musculoskeletal systems, gait normal, arms and legs, both arms and legs are symmetrical, normal muscle bulk and range of movement, and no skin lesion deformity, but bilateral pitting edema over the both feet up to the calf region noted. Spine curvature and movement is normal, no deformity noted. Should I proceed, ma'am?
Yes.
Provisional diagnosis, 11-year-old girl, active, alert, hemodynamically stable, with constitutional symptom of fever, with a fixed rash over nose, with painless oral ulcer, with swelling over face and legs, with anemia, with normal systemic examinations. Probably due to autoimmune etiology, systemic lupus erythematosus with renal involvement, or any malignancy or tuberculosis.
Arun, what makes you think of tuberculosis? Yeah?
Ma'am, tuberculosis in prolonged history, ma'am, fever, and maybe due to the maybe one of the cause prolonged fever and having it without any other causes.
So I think you could say here that lupus is sometimes precipitated by an underlying tuberculosis or tubercular infection. And that
Maybe
is a possibility, but you would not be diagnosing or on the basis of your history and exam this case as a TB case. Definitely, that's for sure.
okay, ma'am.
You may be working up for TB because you're going to immunosuppress the patient. That's okay. But keeping a possibility of TB at this point seems a bit likely. And same with the malignancy. There's nothing in the history that would history or your physical examination or your any in your negative history that would suggest a malignancy. So I think by this time, after a thorough examination in a history, you can confidently say that this seems like a connective tissue disorder. And in your musculoskeletal examination, you have to mention, I know that you have examined it, but you have not written over here. You should mention about the tone and the power as well.
The power and tone is normal.
Yeah, so that's what. So you mentioned the reflexes, you mentioned the no neurological deficit, you mentioned or moving all full limbs, so you should mention tone and power.
Dr. Manjari, just one comment if I can make, you allow me.
Yes, sir.
In this case, which malignancy you are suspecting? Basically, a child presenting with edema. Which malignancy you should have it in mind? And secondly, why should you not put a diagnosis of a chronic renal disease with anemia? It can present with the same manifestation. Which malignancy you are talking about, and one of the differential diagnoses can be a chronic renal disease with all the manifestation it can have. Dr. Manjari, your comments?
True, sir. We could, so it could be a renal involvement, a chronic renal disease, yes. Actually, there was the fever is much more prolonged and the edema is relatively short in history. And there are painless hard palatal ulcers and there is a rash in over the nose and over the malar region. So that is why thinking of a chronic, yeah, so thinking of a chronic renal disease, yes, definitely keeping it needs to be kept in mind. But looking at the whole picture, the possibility seems a little less because this edema was quite recent and the constitutional symptoms were quite earlier. So that is why probably, yeah. And again, the malignancy, the patient did not have any constitutional symptoms apart from fever, apart from fever. And this fever is also episodic, on and off. It's not like a continuous fever. And there are episodes of normalcy in between. Many
Right.
times the fever chart has not been kept. And it's just a history that if there is fever for 3 months, it's a very nebulous kind of a history.
Yes.
So it's not exactly fever for all 100 days, and it's fever episodically.
Right.
So
So malignancy here seems a bit unlikely. Probably Dipti ma'am would want to add
yeah,
something.
no, I just wanted to see that, of course, tuberculosis, even though in India we just like to keep tuberculosis in any chronic febrile illness, but the symptomatology, renal involvement and rash makes it very, very unlikely here. Malignancy, again, I think you can reason it out by saying that there is absence of lymphoproliferation, no hepatosplenomegaly, and the rash itself makes you keep it again very lower down in the card. One of the more important differentials that they usually like to keep in patients with SLE is infective endocarditis, because that's another diagnosis, which is a very close mimicker with multisystemic disease to SLE. So even though cardiac and renal, this thing is always there, but a thorough cardiac examination is necessary. And quite often, infective endocarditis may mimic SLE very closely. With regard
with such a prolonged history of fever,
native valve infective endocarditis, just because there is a persistent fever for 3 months, that I would like to keep that as a differential. Though photosensitive rash, the photosensitivity is odd, but the vasculitic ulcers can occur as well as renal involvement can occur in patients with infective endocarditis. But if fever is impressive, especially going on for 3 months, then that can be also entertained for the purpose of reasoning out in your exam as an important differential. In terms of Arun, in terms of physical exam, I think a little bit of more additional information, especially for hair loss and frontal alopecia, can be talked about. Did this child have any history of hair loss and frontal alopecia? Because
No,
that
ma'am.
is also a surrogate.
Yeah.
Because
Ma'am,
that is also a surrogate
said-
marker for lupus. So
Yeah.
hair loss should be inquired into and looked at in physical examination. And of course, the need for emphasis here would be the blood pressure. So blood pressure is a most vital, one of the most important vital informations that is necessary in this particular case. So those were my comments.
Okay.
Right. Arun, you forgot to mention the BP?
Ma'am, BP normal 110
And
by
he did mention,
He did mention,
and he showed that the blood pressure is normal.
Yeah.
Just for the sake of emphasis, in such patients, blood pressure is
because this patient, surprisingly, ma'am, this patient did not have any alopecia or thinning of hair.
Yeah, no, that's fine. That's fine.
Yeah.
That's fine. I'm just for for education purpose, I'm saying. Not every patient would have everything.
Yeah. I think Arun, do you have any further? Yeah, you've got some investigations. Probably we could do.
Investigation outside, patient having the low HB, for that he was one time transfused PRBC. And on further investigation, if the fever persists, the child having RBC microcytic hypochromic with mild and isocytosis, poikilocytosis, with normal WBC morphology, with the normal platelets. Coagulation profile normal. Child having a routine microscopy, protein plus on 10th April, and with after that 1 month repeating of the urine routine microscopy, child having 10 milligram per DL of the protein and trace protein, but RBC is nil. Blood urea creatinine is 21 and creatinine is 0.5, and child having significant SGOT elevation with C332 and C444.9, child having DCT positive, serum electrolytes normal, child having low albumin 1.80, with USG having hepatomegaly at the 1 month prior, subtle increased bilateral renal cortical echo texture with 2D echo normal. And in investigation in Gangaram Hospital, child having HB of 9.6 with TLC 12,000 and with normal platelet and ELC counts. And child have blood urea BUN 29 and creatinine 0.73, serum electrolyte normal, and persistent low albumin 1.89 with uric acid 14 and ANA raised 1:160 with normal beta 2 glycoproteins and beta 2 glycoprotein IgG and IgM with serum cholesterol 343 with normal coagulation profile. 24 over urine protein is 2263 and volume per 800 per day ml per day with normal anticardiolipin and antibodies IgM, and ACA is IgA is 3.4. Investigation in SGR. On further investigation, renal biopsy showing the lupus nephritis class 3 with activity 6/24 and chronicity 0/12, and basis on the history and investigations, and concluded the diagnosis of systemic lupus erythematosus with lupus nephritis class 3 with nephrotic range proteinuria without hypertension.
So Arun, you could go back to your investigations.
Ma'am, outside or in Sir Gangaram?
You first go to outside.
Yeah.
Right. So what do you infer from these? I assume that the patient was given blood somewhere in between 15th May and coming to our hospital, right? Or was given blood in between 4th April to 17th April?
During the first time CBC, blood was HB was 5.6, and at that time, and blood one PRBC was, and after that, for the seeing the increasing the HB was increased from 5.6 to 7.7 and then 8.8. Then she was not transfused again for that. But fever was not subsides. That's why they have taken the antibiotics from different clinics. After that, even in spite of the antibiotics and symptomatic treatment, child was not recovered from fever or rash. Then they was referred to our hospital for further management.
Okay, now let's focus on these bloods. And now suppose you look at these bloods, and suppose here the TLC count was 15,000 and the platelet count was 6 lakh with a low HB with a 3-month history of fever. And what would you be thinking of?
If TLC may be raised, then we will differentiate the viral or bacterial. But in the bacterial, viral.
No, Arun, you didn't get my question. Listen carefully. So child has, forget this case, child has fever for 3 months. Child has a hemoglobin of 5.6, a total count of 15,000, and platelet count of 6 lakh. What would you be thinking of?
Ma'am, maybe due to the thrombocytopenia.
What rheumatological disease would you be thinking of? With a rash that comes and goes. Which rheumatological condition has got a fever with a rash that comes and goes? It's not a fixed rash.
Rheumatoid arthritis, ma'am. Maybe join.
Arun, systemic JIA.
Jubilant, yes, ma'am.
You're thinking of systemic JIA if you look at high TLC. So lupus is one inflammation where you do not get a high TLC and where you do not get a high platelet. Otherwise, in all other inflammatory conditions with fever, you would typically get high TLC and high platelet count. And that is why when children with lupus present to us with macrophage activation syndrome, it is very difficult to make that diagnosis at presentation because these children already have a tendency to have low TLC and low platelets. So it's not easy to make a diagnosis of mass in these children who've got lupus. And that is why lupus mass has got a very high mortality because it is not diagnosed on time. And many of these children do not get the appropriate immunosuppression on time. Probably Deepti ma'am would like to ask you a few questions on the investigations.
Yeah. So what all are pointing towards lupus here in your investigations? So let's go one by one. What abnormalities have you been able to identify in your investigation profile, common investigation profile?
In my investigations, low HB with urine routine microscopic trace elements with SGPT, SGOT raised, and with low C3 and C4, and having hypoalbuminemia involving the SLE with rash with SL in having occurred in the SLE with the involvement of renal also involved, and that's why having hypoalbuminemia with raised SGPT,
Okay.
SGOT.
Okay, let's first talk about the liver dysfunction, SGOT, SGPT elevation. Yes. Why do you think does the patient have SGOT, SGPT elevation? And what does that indicate to you?
Due to the chronic infections, may be raised LGBT in this case.
With infection where, I mean, your patient has SLE. So in the setting of SLE, how are you going to interpret this SGOT, SGPT elevation and explain the OTPT elevation here?
In my case, ma'am, if there is abdominal involvement with peritonitis or infection, in that case, as SGOT, SGPT may be raised due to infections.
No, Arun, ma'am is asking in this case, in your case, how are you going to explain SGOT-PT elevation in your case?
What could be the causes here? So you have a child who has SLE. She has needed a blood transfusion and she has an OTPT elevation and she is DCT positive. Now, can you think of the reasons why SGOT? And SGOT here is clearly more than SGPT.
More than SGPT.
Yeah. So what does that indicate to you? What could be the reason?
So Arun, what are the sources of SGOT in the body? Where does SGOT come from? Apart from liver, does it come from anywhere else? Or is it specific only from the liver?
So anyway, so this, should I just explain?
Ji ma'am, ji.
So I think when you think this SGOT, SGPT involvement is important in patients with SLE, and you be very carefully look at it. And this is because, one, it can be, as expected, a hepatic disease. But it could be because of hepatitis or hepatic involvement or lupoid hepatitis. That means renal liver involvement in patients with it. Or it could be secondary to the drugs that the patient has received. Hepatic damage has occurred. Or thirdly, especially when you have SGOT elevation, which is more than SGPT, this is a surrogate marker for ongoing hemolysis. So with SGOT, SGPT elevation and a DCT positivity and a hemoglobin dropping to as low as 6 grams, this is an indication that the patient probably has an autoimmune hemolytic anemia, which is a manifestation of SLE. So one of the organ systems that is involved is blood or hematological involvement of AIHA and hematological involvement with SLE. Is that clear?
Arun, are you here? Have we lost you?
Am I?
Yes, ma'am. Ma'am,
Yeah.
but there is no history of any drug intake or like
So that,
tuberculosis may
so
cause
if there is no such illness, then it's all the more suggestive that this is because of a autoimmune hemolytic anemia,
Okay, ma'am.
because of SLE.
जी मैम.
Urine के लिए पूछ लो, Manjari, you can explain the urine.
Yes, ma'am. So Arun, when you are looking at this urine routine, then what would you think of over here?
Ma'am, urine protein having a trace protein, proteinuria in the urine, and which shows the involvement of the kidney.
But this protein of 1+, what more you should be writing over here? This 1+ protein can commonly be seen in which situation? Normally, in normal patients also.
Ma'am, UTI may be with.
Okay. In normally.
High protein diet may be contained.
High protein diet. Okay.
Yes, maybe show.
Anything else? So if you, what would you look for when you have a urine trace protein or 1+ protein? What do you look at in the urine? What do you want to know? You want to know about specific gravity. So you want to look at the urine routine. You want to look at the specific gravity. You want to see whether this is a concentrated urine. A very concentrated urine may also give you trace proteins 1+. And also, what do you want to rule out? You want to see whether it is a first morning sample or a ambulatory sample. What can happen in an ambulatory sample in normal people? What can you get?
Bacterial with growth.
You can get orthostatic proteinuria.
Okay.
So you can get orthostatic proteinuria in normal people after prolonged walking. Also, if it's a hectic sample, after hectic day, a sample has been given, then it could have some orthostatic proteinuria. So we always prefer in lupus patients to rule out the orthostatic proteinuria. We always prefer to have a first morning sample. The first sample when the patient wakes up in the morning, that sample is usually taken for a urine routine as well as for a spot protein creatinine ratio. And here also your serum albumin is much low and this urine protein is not corroborating with such a high degree of serum albumin. But then of course your 24-hour urine protein, which you have showed in the next slide, it of course corroborates this is a nephrotic range proteinuria, where you are getting this high protein. And over here, probably you've not written the urine protein of our hospital, which was 3+.
Okay, ma'am.
Probably the other labs were not corroborating it very well. And so probably your patient also had some AKI, your uric acid was 14.
Yes, ma'am.
Yeah, and your APLA were negative. So these are all lupus specific bloods. But if we really look at simple investigations, a simple CBC, a simple SGOT-PT albumin, a simple creatinine, a simple urine routine can also give you a lot of information, even without going for a huge immune profile. So APLA workup is a different part. And, of course, look at the serum cholesterol. So this is like a nephrotic syndrome. But the patient was not hypertensive. That is the only different thing over here. So the patient did not have any blood in urine. So she did not have any nephritic features, right? Right, ma'am, would you like to ask him?
Yeah. So if you are suspecting, that's, I think it's very important to recognize that there is renal involvement, quantify it as Dr. Manjari said. This is corroborated here with low serum albumin and high serum cholesterol. So it is a nephrosis-like presentation. And I think that part we can take again later. But let's talk about ANA first. If you have to order ANA for a particular patient, how do you order if you're suspecting lupus, and what titers do you take it as significant? Do you specifically ask for a particular method or something like that?
There is no special method for purpose test. If the patient presenting with fever or rash, then we will
ANA.
ANA, yes, ma'am, for ANA.
Yeah, so what method of ANA would you order? By what method would you order? So this ANA that you've written, what method was it done by? So do you know there are, how many methods are there to do the ANA commonly commercially available?
Ma'am, due to enzyme immunoassay or multiplex immunoassay.
ELISA, yeah. So ELISA, and what is the other one?
Multiplex immunoassay method, ma'am.
No. What is the other one? Immunofluorescence. So
Immunofluorescent, ma'am.
indirect IAF, indirect immunofluorescence, right?
Okay, ma'am.
So when you look at ELISA, you get a single value. And when you look at immunofluorescence, indirect immunofluorescence, so you look at titers. So you do it in dilutions.
Okay.
So I think you need to read up about it and you need to look at it carefully. So what titer is significant? A titer of 1:80 is considered as significant.
Significant, yes, ma'am.
Arun, I thought you knew most of these things. I think you're getting nervous.
No, 140 normal and greater than 1:80 is significant.
1:40 is insignificant.
Yes, ma'am.
Nobody does it. Even they start only looking at it from 1:80. And if 1:80 is positive, then they start looking at higher dilution titers. So then they dilute it further and then they look at 1:160, then 1:320. So then it goes in the multiple of 80s. And 1:40, nobody does. So any titer of 1:80 or less is not considered significant. The entry criteria should be 1:80 or more. So that's your ANA, and the method is indirect immunofluorescence using HEP2 cell line. And this HEP2 cell line is human epithelioma, which is a laryngeal tumor. So that cell line is used, and it is used for the sake of our audience. So this is used mainly for so that it expresses the antigens very well. This cell line. So the cells are big and they express the anti-nuclear antibody. So this is all the cells, all the nuclear antigens are eluted out, and these nuclear antigens, when they are seen by our immune system, then the immune system thinks they're all foreign molecules, and the immune system forms an antibody against them, and that is the ANA that we measure. So all these antigens are expressed very well on the human epithelioma 2 cell line, and that is why commonly this cell line is used. Historically, the LKM, the rat liver cell line used to be used, but now we are not using that any longer, and we are using Hep2 cell line, or some labs even use Hep2000 cell line, which may even have a better expressivity for Rho antigen. So this is just as an add-on. It's probably not very relevant for you guys at a DNB exam level, but definitely you should know that there are two methods to run the ANA, the ELISA and the immunofluorescence, and the preferred method is the indirect immunofluorescence.
In addition, there's one more basic advantage of ordering it through IF, because you can see a pattern. So it is like diffuse, homogeneous, rim enhancement. So all these will also help you identify the underlying disorder. Sometimes they're specific and give you see different patterns. So IF can give you pattern, ELISA cannot give you patterns. So that is why in indirect immunofluorescence, ANA by IF with an entry criteria of more than 180 should be taken as significant, and it should be ordered with IF. So that's an important part.
Okay, ma'am.
Can we go to the renal biopsy? What were the indications of doing renal biopsy here? So complements were low. So low complements, ANA positivity. We don't have the dsDNA value here, but dsDNA. If we have dsDNA value, that will be helpful. So the diagnosis of SLEs with autoimmune hemolytic anemia as well as leukopenia. There is no thrombocytopenia. So SLE is nearly confirmed. So why would you want to do a kidney biopsy here? And what are you expecting to see in kidney biopsy?
Ma'am, if the child having 500 and with rash, then we to look for the extent of renal involvement in SLE. Due to the complication of the SLE, I have to perform the renal biopsy to look for involvements. And with the renal biopsy involve a single linear core measurement. After renal biopsy, the renal biopsy showed the lupus nephritis involvement of the kidney and class 3 involvement with the renal function involvement, ma'am.
Arun, so would you biopsy all the patients of lupus to look for renal involvement?
Ma'am, if child having a persistent elevated proteinuria or low complements with the hyperalbuminemia, then we should perform the renal biopsy to look for extent of renal involvement.
What level of proteinuria would you tolerate, and what level of proteinuria would you not tolerate?
Greater than 500, is greater than 500. If patient having urine, then we have to do renal biopsy. If less than 500, then it can be tolerated or should be deferred for renal biopsy later stage, with or without involvement, or with or without having hypertension or not.
So you were saying that you would be looking at a patient where the patient would be having a high proteinuria, a protein range of more than 500 milligram in a day. Is that what you're saying?
Yes, ma'am.
And suppose the patient does not have it, but something else. So if your patient has got RBC cast, if the patient has got granular cast, so active sediments, these are called active sediments. So if your patient has got active sediments, then you would think of a biopsy. If your patient has got, even if your patient has got a 500, 600 milligram of protein, but a lot of cellular cast, granular cast, RBC cast, so you would be looking at a kidney biopsy in such a patient. So a urine routine is equally important as much as a 24-hour or a spot protein creat ratio is important. And this urine routine, simple investigation, but gives you a lot of information And especially if read properly, if done properly, you would. And now most labs are doing a quantitative analyzer. They're not doing it manually any longer. So it's even better that they give you a lot of faff, but you get some worthwhile information when you are running it through an analyzer. So that is very important, that you should look for an active sediment. So so sometimes you would tolerate this 500, 600, and you would wait for some time. But in such a high degree of hypoalbuminemia with hypocomplementemia, you would not wait, and you would go ahead and do a kidney biopsy.
And should I proceed, ma'am?
And then, Manjari, do we take it right up to the management, or?
Ma'am, I think we could leave it for them. It's
I know, that's exactly why. So
yeah.
The thing here is that patients, you recognize multisystemic disease and the renal involvement. Nephrotic range protein, nephrotic presentation, or pure nephrotic presentations would need renal biopsy. And in patients who especially in patients who have hypocomplementemia. So if you could just enumerate other causes of hypocomplementemia with renal involvement. I mean, if you are aware of other than SLE, any other disease in which you can see this combination of hypocomplementemia with renal disease. Any idea?
Immune complex mediator manifestations,
Yes.
ma'am.
Okay.
Glomerular
Post-infectious GN.
and cryptoglobulinemia, ma'am, maybe.
So you can see it post-infectious GN, shunt nephritis, infective endocarditis. So these are essentially important causes of hypocomplementemia along with renal, but SLE being the most important. And if you have to differentiate it with PSGN or PIGN, then the full house pattern that you see in biopsy, that means if you look at your immune can you put the biopsy slide?
No, ma'am.
So if you look at the IF here, you have 3 plus IgG, 2 plus IgM, 2 plus IgA, C3, 3 plus, C1Q, 2 plus. So it's not pure IgG or only IgM or IgA. It's all the antibodies which are present in significant number, and this is called as full house pattern. And this is sine qua non, I mean pathognomic of lupus nephritis. So your biopsy has helped you confirm the diagnosis, and then definitely it has helped you in staging the disease. And that is the reason why referral and identification is important in such patients for lupus nephritis, and looking for the full house pattern. This is class 3. So class 3 classically has a nephrotic presentation, but probably absence of red cells here in your urine routine is suggestive more of class 5, but pure nephrotic syndrome. But your biopsy is saying that it is class 3 nephritis. Manjari?
Ji, ma'am. I think it's I think these bachas are going to flip.
Yeah, I know.
Just
to tell them that full house, they should
Yeah.
look at the IF in kidney biopsy. That's important. Management wise, corticosteroids remain the mainstay of treatment for patients with SLE, along with HCQS, and subsequently you can use cyclophosphamide or mycophenolate.
Right. So I think Arun needs to read up a bit more about lupus and read around it. But good presentation.
Thank you,
Arun.
Arun, for good. I hope you understood your patient well.
Apart from
Done a good
specific,
presentation.
thank you, ma'am.
Thank you so much, ma'am, for your time.
Thank you.